finding I actually getting as well and I said even in the case of my people myself just there was really enough as well doing supposed to be in the first 2 years of my diagnosis. Don't confidently believe in the needs of 6.5 or above. Unless there's a rare place where it's related and you have been thinking like that is still giving great symbol. Move is very people following when you use ATG versus a move, you can bring it over and bring it to my collaborators, particularly in London group, putting all this data together and then seems to be the recently leading patients. I always show this slide at the end because this is what it's all about. These are patients who are significantly disabled who I don't even know whether since they were enjoying going after HSCT, going hiding history from being going to be farming, getting things that he would be really running the entire field and telling us they were waiting over the procedure. But I think that someone to put in this time and different power was possibility. So we are gonna move to our next speaker, Dr. Silvana. Because I want to have my welcome to Netherlands and you're from Netherlands, an assistant professor of medicine at Swat University Real. I think there's a lot of finished here and then he began hospital from 2012 to 2017. Then he finished his clinical work John McGinnis, Jonathan. So he's now a young male business man at King's South University Hospital. What he was talking about and animal aspects of disorder. Thank you very much for the introduction. You probably be here today, this nice day, a nice city, historic city, Yemen, holy city of Medina. Slides up. So we today talking today about animal assembly review and then review slides in the management. And, so these are my disclosures. This is the outline of the talk. So this is my experimentation of AI. I think the theme today is the AI images. It's always the big pictures seem to be monochrome, white and black. So let's make it colorful. And this is what I got. It's similar to what it was, not like John was by black, but little different. So anyone who did that, we always realize that this is not a typical MS phenotype where a patient has severe optic neuritis, myelitis. We used to think of it as a MS subtype, MS variant. However, studies that show there's presence of specific antibodies against alcohol, foreign antigens, the astrocyte that are very specific to the disease. And then this led to the discovery of these antibodies to the discovery of the phenotype and more phenotype and expansion. Seed is variable, it's present on almost all population with variable prevalence. As you can see, areas like Martinique on the left side, where there's like up to 10 per 100,000, it's still there, disease not as common as MS. However, it tends to be more prevalent compared to the like African countries or people from African descent, and also East Asian or Asian descent, for example. And they didn't tend to affect a specific part of the CNS, typically the optic nerve or the spinal cord. And there are cases where we have area of schema. These areas that are rich with up to 1.4 in core channels near the periventricular areas. And there's a strong association with systemic connective diseases such as lupus, Sjogren. So these are usually unique features that tend to make us all think about animal and differentiate. There is a recent cases or case report of animal antibodies targeting antigen outside the CNS. For example, this is a patient who has severe pneumonia when they're having like a biopsy of the lung where there's like a loss of stain of these channels. So, and the same patient also did have neurological manifestations. So they start to think that in some cases which are rare, this could be a manifestation of NMO that's outside the CNS. So the spectrum is expanding even outside the neurological system. So we just looked at our patients in the center. Our center is not that huge. So we have about like 20 plus patients with NMO that have treated over the last 2 decades. And we can see that the outcome of the disease is tend to be very severe. But you can see that some patients will end up being blind in one eye, or some of them even in both eyes. And this is not something that we typically see with multiple sclerosis. So this disease tends to be more disabling, tend to be more associated with mobility complicates my lifestyle. As you can see, most patients end up requiring some sort of walking aid, and some of them were in a wheelchair. The slide. And this is in our patient, the disease is unique because it tends to affect mostly female, like 9-to-1 ratio. And this is almost like across all the board, it's kind of a similar observation for body dependent. And this can occur in any age from children up to elderly. So, which is different from MS, which usually have short-term age span. Maybe little next. Okay. So this is the manifestation. We tend to diagnose NMO with the criteria published in 2015 by Winkelshire. And as most of us know that when you have antibodies against those channels, it's easy. You just get one attack, one of these attacks, and this is a diagnosis. This will change more or less minimal changes when you have antibodies. In the new update, which is not yet published, there's going to be inclusion of brainstem and cerebellar attacks in the future. It used to be brainstem, now the cerebellar. And we also mentioned the focus on some specific or unique finding in those patients, such as atomic spasms, which need to be gained for patients. And also the neuropathic axial pruritus, which is also a manifestation of myelitis animal. So that kind of unique that make you think about it rather than MS. So the new criteria also focus on seronegative cases. It's going to be also a more difficult aspect of animal. Can you move the slide, please? They also, in the MRI, we tend to look at the area posterior. Traditionally, this is a hot area for the disease. In the new criteria, also included the cerebellum, the dentate nucleus as a potential area for animal. And also, typically, we're going to also look at the usual periventricular location. So there's going to be a little few updates on the new criteria in terms of the areas. So you're going to see update in NMS criteria, also in NMO criteria for different flavors. Testing is always an issue with NMO because of the need to do like live cell-based assay ideally, which are not always available commercially. So most of centers send tests by fixed cell-based assay. So what we do usually. These tests are kind of acceptable. And the new criteria, they say these tests can be done using fixed assays. However, if you are really want to exclude animal completely, and the patient has really suggested phenotype for repetitive fixed cell based, you probably need to do live cell tests, which is not always available. ELISA tests are completely I wouldn't say use this, but it's not recommended because of false negative, false positive ratios. There are interesting tests that have been in the discussion lately. One done by an Asian group, the rapid immuno.assay collaboration between Chinese, Korean group, would show that this is actually a faster and highly specific methodology, but it still needs validation by different centers. There's also the dried blood spot test, which is very simple test. You take dried blood and then you can send it in an envelope, ship it to any big center. This is a study that I've done with the collaboration with Mayo Clinic and African countries, and it actually showed very good accuracy this way. So the testing is an issue. Hopefully it will be easier with the new tests. Next. And the cases where there is like no antibodies, this is all the issue. This is usually the challenge when you have no antibodies. So you are not sure this is NMO. Should I treat the patient as NMO, or should I just look for other diseases? And this has been also being a challenge in the new criteria for seronegative cases. There's a debate, they should be called disorder or a syndrome. And If you can see in the next slide, here they said that it's something what we call NMO spectrum, where you have the classical NMO phenotype, like optic neuritis and myelitis. This is maybe you can include it as NMO. However, there is the clinical phenotype, and the patient have recurrent optic neuritis, myelitis. These problems that we call NMO. So this is still a work to be done by the group who are making the criteria to dealing with seronegative. We know the seronegative patient don't respond well to treatments such as tocilizumab or eculizumab, works very well for seropositive cases. So they do behave different. Next. The biomarkers has been always a hot area of research in MS and NMO. The serum GFAP, which is an astrocyte protein, has been so strongly association with NMO attacks and NMO disability, which seem to be relevant during the attack and before the attack. As per the study, this is from the momentum trial. They looked at NMO patient before the attack, during the attack, and after the attack. And you can see that the rise in the GFAP titles, and then they go down. So this might be a very promising marker for NMO. And this has not yet been endorsed by the criteria to prove these biomarker opportunities, but they can be done as part of research. Next. So we're going to talk about the acute treatments. We tend to treat relapses like with what you do with MS, with osteoarthritis, with steroid, steroids. Or there is a good evidence that initiation of plasma exchange early on the relapse has been associated with strong rates of recovery and lower rate of disability. So we the recommendation advise starting plasma exchange early on during the relapse, especially in disability. There is also a recent multiple cohort, multiple actual case report of patients responding well to complement inhibition shortly after the attack as a rescue therapy. And there are some anecdotal studies that show this may be even better than plasma exchange for acute relapse, giving like eculizumab, ravulizumab. So this is might be a really interesting approach to treat relapses that can spare the patient the central line and the complex plasma exchange. We look at our data, and you can see in the right lower side slide, we've been only using plasma exchange for NMO attacks only in the last maybe decade or so. So there is still underutilization of this, and this is what explains why we still have a lot of disability within them. The prevention of relapses is the mainstay of this disease. One of the relapse of the patient, severe disability, make it blind, paraplegic. So the prevention has been traditionally achieved with azathioprine, phenolate, methotrexate, and traditional immunosuppressant. Then early in 2000, people started using rituximab, which have shown significant actually effectiveness. And then most recently, we're lucky to have a treatment for NMO instead of treating it as off-label by targeting the complement inhibition, mimc2026, and also CD19. So these are new medications that target different pathways in the disease pathogenesis. You can see in the lower part of the slide the B lymphocyte, which is responsible for development into plasma cells. They're making these antibodies, the pathogenic antibodies. This can be targeted by elimination of B lymphocytes through CD19 or CD20 by rituximab and eculizumab, or by the reduction of the development of these plasma cells by using interleukin-6, such as tocilizumab, sacituzumab. The most effective strategy is at the end of the pathway, where this antibody crosses to the cells, to the CNS, and then they bind to the astrocyte. And this is where they activate the complements. And when you activate complement, it will cause more inflammation and causing also damage to the cell. So when you block the complement, you achieve almost complete prevention of these relapses. And this has been so far the most effective strategy. And there's been some evidence for rituximab, and always been told there's no clinical trials. There's no large good clinical trials. The list we have is a Japanese trial that showed when you give rituximab for 20 patients compared to placebo, there is almost no one relapses. However, we need to know this is number of patients small, like 19, and most of them were on prednisone during this part of the study. So it does seem to work successfully, at least for those patients. So if you give rituximab for anymore, you probably notice some of them do relapse, even with rituximab. Usually this happens in the first year of rituximab, especially when the patients are not on prednisone. So studies have shown that the lower prednisone doses in the first year is associated with higher risk of relapse, even with rituximab. So that's probably what we should do, give more rituximab during the first. And then there is a nice presentation by German group about spacing out the dose for animal breast. Because this is a disease that is lifelong, treatment is lifelong, so most patients will be depleted for B-cells for a very long time. So there's a question: do we really need to do this all the time? So the next infection is going to be higher, and this is what we just saw. Sweet experience, almost double risk of infection, serious infections when you give a toxin. So they try to space out the dose for patient with anemia. They give fixed dosing every 6 months, and then they give the flexible dosing, and they compare them. And they notice that there is actually no difference in efficacy, but there is a reduction in infection when you do this spacing out of the clinic. So this seems to be a good approach to do. Probably, I think maybe after maybe 1 year or two, not as good as in the first year, but at least we can think about down the road. So their thoughts that maybe giving higher dose is better than lower dose, but spaced out. So I'm thinking maybe this is the way we think of it. Just give 1,000 only when the B cell repopulate. There is also pertuzumab, which is a new medication we use a lot in MS. It's the same mechanism of rituximab, more or less, by depleting B cells. So the question is, would it work in animal? There's a Chinese study using patient excerpts, and they compared pertuzumab to the distribution suppressants in animal patients. And actually, the results showed that there was good efficacy on pertuzumab, as you can see, compared to cells. So this might be a good approach to use in patient animal. So we're lucky to have those treatments. So the traditional approved treatments nowadays are eculizumab, ravulizumab, these complement inhibitors. The main issue with those medications is the complication of meningitis, especially Neisseria meningitis, and this has been the most common issue that we face. Also, there is the interleukin 6 inhibitors, which has been reasonably effective, especially in seropositive cases, in addition to emicizumab, which is targeting CD19, rather than CD20, giving it wider spectrum. The real-world data of these medications seem to be reassuring. As you can see, the relapse rate is very low. A lot of patients remain relapse-free with emicizumab, interleukin 6 inhibitor. Our patients are treated mostly with rituximab, few ravulizumab, few celcib, and one tocilizumab. Just like to see are we doing similar to what done elsewhere. And this is the last slide showing you that there's upcoming pipeline for NMO, including different treatment approaches that hopefully will lead to maybe safer approaches with safe efficacy. This is actually not a slide. This is the slide, or actually not a slide. This is a guideline. We're happy to walk through this effort led by Professor Jimma. And we established this consensus on how to use those medications for NMO3. This is actually the second iteration. It's like 3 years from the first one. And we suggested this time to use monoclonal antibodies as a primary therapist, even rituximab, which has not been traditional, but all of us are using it anyway. And also, we debated a lot about should we use covalent inhibitor as a first line because they work better. And we suggested that some maybe should be used in special severe disease. The main issue here is the costs, because the covalent inhibition is very expensive treatments. And this is a severe disease. We need a lot of way to test it better, faster, more cheaper. And the challenge still with seronegative cases remains a problem. Thank you very much. I'm sorry if I want to bring that further. Thank you. Always speak to this just me like leaving songs and doing survives. Thank you very much for the nice introduction, and thanks for the organizing committee for inviting me today to speak. So we'll speak today overview about pediatric MS and Mugat. I have nothing to disclose. This is my outline of my talk. So pediatric MS is considered one of the rare forms of multiple sclerosis. It's estimated about 3 to 5% limits cases, and some reports mentioning up to 10%. So, and also it's extremely rare in less than 10 years of age. And you need to think of other MS mimics, including genetic disorders. 20% of all pediatric acute demyelinating syndrome are diagnosed with MS. And the study studied the prevalence in Saudi Arabia, pediatric multiple sclerosis, and found to be 2.73 per 100,000. And the sex distribution is similar between male and female. However, it's been changing to be more female predominant after the development of age. The risk factor on the pathogenesis is considered the same as in adults. So the same disease, but however, there's some difference. We'll speak later on. It's important to note that most of the time, pediatric MS has relapsing remitting. However, there is a report of less than 3% of primary progressive MS. So there's a lot of a challenge in diagnosis of pediatric MS. The first is the rare disease because comparing to the adults. Also, there is a lot of mimics. As we know, there is a lot of hereditary white matter disorders, leaky dystrophies, autoimmune condition that it is very challenging to diagnose with pediatric MS. Heterogeneous presentation is more age dependent. As we know, younger age of children has different phenotype of more encephalopathy or encephalitis-like pictures and seizures comparing to the older children. As we know, the kid's brain is still developing, and whenever having inflammatory in this critical period of time, that will have a huge impact in the future regarding the cognitive function and the learning ability. We have a limited trials data and approval in pediatrics. There is some challenge to have an access, especially the higher victim crowd. Also, treatment adherence a little bit harder in the kids. As we know, the school absence as well as frequent appointment in the hospital, as well as the sedation logistic doing the frequent MRIs, is a bit challenging. So what are the difference between pediatric and adult MS? In the pediatric MS has more of inflammatory active disease and more relapsing disorders comparing to the adults. Also have more total brain MRI lesions, more contrast enhancing lesions, as well as more infratemporal lesions. Despite the high active disease in the children, however, they have a better recovery from the relapse comparing to the adults. As we can see here, these studies show the EDSS improvement decline with time. In children also have more long-term cognitive consequences with greater faster decline over time. As you can see, the green line, pediatric onset for the cerebral digit modality testing have more acute decline, especially after only 25 years. Also, in the children have more slow long-term disability accumulation. However, the reversibility of the disability progression and disability more than 10 years earlier than adult MS, and this is most likely due to the earlier onset of MS. So there are some red flags in diagnosis pediatric MS, and one of them was if you have a very young child, less than 10 years old, is considered red flag. If you have a developmental delay or positive family history of any neurogenetic disorders, or insidious onset rather than an elapsing limiting time. And there is, as you can see, a lot of mimics in pediatric MS. Uh, the top differential is acute adult demyelinating syndrome like Williams, Morgan, and Barenboim. Also, neurogenetic disorder like leukodystrophy, hereditary spastic paraplegia, as well as mitochondrial disorders. And also in HLH is quite common in our region, specifically if you see a pediatric patient with predominant posterior foci movement. So going to the history of pediatric MS diagnostic criteria, this is a timeline showing how the pediatric MS criteria evolve with time. And as you can see, that the 1987 showed the first scientific report published describing pediatric lymphomas. And then the diagnostic era has been started in 2004, the first diagnostic criteria on the kidneyscope, and followed by 2010 McDonald's criteria as well validated studies in different literature and research shows that we can be using in the children. However, with to be important in patient below 12 years of age and patient who has a symptomatic presentation. In 2012, also the consensus definition of pediatric MS and the criteria and the definition of other demyelinating syndrome was published by the International Pediatric MS Study Group. In 2017, McDonald's criteria also being well studied in the children. And as we can see, there's good accuracy and sensitivity comparing to 2010 in diagnosis of MS. So this is recent the MS diagnosis already described like what we want to plan that I just want to highlight a few points in pediatric diagnosis. The first is the same framework, diagnostic criteria being used in the adults are the same in the children. Should not be used in adult presentation. As we need a second clinical attack consists of a typical MS and more lesions or more lesions in the follow-up scan show typical topography of MS and 3 months after end onset. More IgG testing by cell-based assay is strongly recommended in patients below 12 years of age. And also it's recommended above 12 years of age if you face a typical presentation of MS. And the presence of central venous signs more than 50% also strongly support diagnosis of MS in children. So as you can see here, the treatment of the registry approved medications in the adults. However, if you compare to the children, we have only 3 medications: the fingolimod, temozolomide, and the dimethyl fumarate. And this is the underlying clinical trials. Some of them are completed, some of them are still ongoing. So we have the paradigm study, fingolimod versus interferon, the first approval medication to be used in children. As you can see, with the significant decrease in annualized relapse rate to 0.12 versus 0.67, with 86% relapse-free at the end of the study. And we have intercase and connect studies, limited open label for alatuzumab, however, it was terminated due to the low number of enrollment and the safety profile of this medication. Operator 1 and 2, examining the ocrelizumab versus fingolimod, and real study of ofatumumab, fingolimod versus fingolimod. Here is the Operata 2 preliminary result that was talked in the last extras, 25 are available. And interesting that have a preliminary result that met the endpoint, primary endpoint, as ocrelizumab was non-inferior to fingolimod. As on in analyzed relapsing rate with the risk reduction reaching up to 48%. Also found that ocrelizumab was more superior than fingolimod and MRI endpoints, fewer MRI lesions as well as few contrast enhancing lesions. There were no unexpected events which withdrawal from ocrelizumab The dosing regimen was studied in operative one and found that in less than 35 kg to be given half the dose, which is 300 milligram, and above 35 kg to be given less than the full dose of adults. If you go for real world data, we have a lot of studies that show the improvement of high effective therapy in pediatrics, including omcrelizumab, natalizumab, as well as rituximab, and with the good efficacy in decreasing analyzed lapse rate in the children. And this is just few studies show the significant decrease in analyzed lapse rate after using the high effective therapy and new medication compared to old medications. And this is a summary of the literature showed, as you can see, that analyzed lapse rate perceived in the new medications compared to the old medications. This is why the MS-based registry, the Italian registry international study showed that if you start high effective therapy in the pediatric age group from 12 to 17 years, you will have reduced risk of disability worsening and less ALS in the future, especially after 23 years of age. And this is comparing to the adults if you use the disease-modifying therapy in the adult age. Also, not only for analyzing lapsing rate on disability, also the study the academic performance in the children and the cognitive function. As you can see here, the worst outcome of academic performance seen in patients with MUGAT, followed by pediatric MS, was not in high effective medication therapy. And after this, a lot of data, we see as a progressive in management in pediatric onset in the last decade, as we usually see how we change in the practice to use more high effective therapy labels in treating in pediatric MS. And not to forget other domains like symptomatic management, family support, and cognitive, as we need to treat the patient as a whole and to improve the outcome as well as the quality of life. So this is a 5-year-old girl, and she presented with a progressive headache, lethargy, and ataxia. As you can see, the MRI showed white matter lesions super and inflammatory. And some of them in corpus callosum as well as in the juxtacortical. However, back to the history, he has a history of ADEM 6 months prior to this presentation. And he has positive MOGAT and with increasing titer. So this is just an example of that we need to do MOG antibody in patients, and especially the children that have 12 years of age. So in regard to MOG had more prediction in the children, representing up to 40% of demyelinating syndrome in the children. And the current estimated range from 8 to 4.7 per 1 million. And it represents up to 60% in all ADEM cases. And also half of the children with accompanying for seronegative found to be positive in MOG antibody. So just a few points about MOG antibody, as patient wanted to submit regarding antibody war. We need to do it on a cell-based assay, as we know that ELISA is not having a lot of false negative and false positive results. Serum is prepared to be sent for the MOG IgG. However, CTF might to be considered if you have highly likely patient with MOGAD with a seronegative. Also best to be done during the attack and prior to immunotherapy, as the MOG antibody is quite sensitive to the medication. You will face false negative results sometimes. And in this such case, you need to remain the MOG after the MOG. And also should be done only in patients with highly suspected MOGAD. As we know, MOGADs can be falsely positive in low titer in other inflammatory conditions, as well as in sometimes in MS of 0.5%. So clinical feature of MOGAD is varies widely, and we see encephalitis, optic neuritis, and ADEM presentation. Sometimes be overlapping with the same patient at the same time presentation. And also all study about multiphasic ADEM found more than 95% are positive in MOGAD. So this is just a difference between adult and children, that the children has more ADEMs followed by optic neuritis compared to the adults from having more optic neuritis followed by transverse myelitis.
This is the recent criteria 2023 by International Organ Panel. As we can see, we need three elements. The first is to have poor clinical demyelinating syndrome with positive IgG testing. Clear positive means that more than 1 to 100 in the. However, if you have a low positive titer, positive without titer, or you have isolated CSF positivity, so you need two extra elements, which is negative occupying bar, as well as more than one supporting features. Also, we need to exclude better diagnosis, especially MS. So regarding supporting features in Morgat optic neuritis, usually it's a bilateral involvement and longitudinal involving more than half of the optic nerve, and especially on anterior half. Also, cranial optic sheath, as you can see in the MRI, as well as optic disc edema, is characteristic for Morgat optic neuritis. In regard to transverse myelitis, in Morgat, usually it's a longitudinal extensive myelitis involving the central cord lesions, sometimes resembling H sign, and bonus involvement is quite common in Morgat. In regarding of brain and brainstem involvement in the Morgat, you can see like alien presentations involving the deep gray matter, and up to 10% in younger children can present with a liquid like pattern. Also, you can see some cortical encephalitis with or without leptomeningeal enhancement, sometimes be unilateral or bilateral. And also, they tend to root the inflammatory lesion involving the pons and the middle cerebellar duct. So, in regard of treatment of Morgat, any presentation acutely should be managed as the same other demyelinating syndrome with a steroid, IVIG, and plasma exchange if needed. However, we know that the children up to 40% it's relapsing disease. So the recommendation to start maintenance immunotherapy you recommend after the second attempt, as the majority have monophasic. However, you can start the early initiation of highly effective therapy to control the relapse in case of severe further. So for how long the tablets to already Morgat, there's a lot of study tried to figure out the duration and the dose. And it's, the risk of relapse was significantly lower in patients if you did more than 3 months in compared to less than 3 months. Also, another study on the right side of the slide showed that a minimum of 3 months with the optimal dose of 12.5 milligram in the adults and equal to 0.16 milligram per kg in the children delay the time for the first relapse in Morgat. So Morgat treatment as a maintenance therapy, we have azathioprine, mycophenolate, and monthly IVIG with showing good efficacy in decreasing relapsing rates in children with Morgat. And in regard to rituximab, there's some controversy in the literature. As you can see in the left slide, there's some evidence showing the improvement of rituximab in decreasing the relapses. However, the right slide international study with 121 patients. As you can see, there is a lot of blue drop sequence and relapses after using rituximab, with more than 70% of patients relapsed showed that the B cell was suppressed during the relapse. So it seems that rituximab is not as effective as an antiviral. And regarding tocilizumab, it's a promising medication. And you can see the left slide of the study showed up to 80% showed relapse-free after starting with tocilizumab. And also showed a better efficacy in one of the study recently published comparing to rituximab in decreasing relapse rates, as well as it had been used as a case report in 2 cases as acutely in ICU patient with refractory Morgat. There's a lot of studies showed that for a different disease-modifying therapy, and they found that the IVIG has a better efficacy in decreasing relapse rate. And sometimes some studies, most studies reaching to up to 70% relapsing free with the IVIG, comparing to 40 to 50% in other disease-modifying therapy. This is a nice survey for neurologists and neuroimmunologists, pediatric, trying to explore treatment approach. And you can see there is a lot of variability in managing that. The majority they choose rituximab as a disease-modifying therapy, followed by multi-immunity. And they have about half of the neurologists vote for less than 2 years of injection medication. The outcome of MOGAT is considered favorable compared to atopic. However, you can see some significant disability, especially if patient presented with transverse myelitis. So in conclusion, pediatric evidence transport dramatically with the current evidence supporting early initiation of highly infected. And more antibody testing need to be done at the first attack in younger children, as well as in all older children if you have an atypical presentation. To differentiate between MS and MOGAT. And pediatric MOGAT require compatibility myelinating syndrome with early cell-based MOGAT positivity and frequent relapses leading to test. Thank you very much.
Yes, this is on the effectiveness and God and the efficacy of this one I'm having. So now we mention our question. So we are this one questions. We have the first presentation by Prof. Alex. The second presentation is what about and transformation by Dr. Pauli. Then we move to the channel and the last session about the so the round any question. Yes.
Thank you so much. This was a very nice session. I have questions from Dr. Kasman. We had a very nice material, diverse, with it also, I agree with when something like that, right? I can just stress that it was no rotation patients in the SSO6. I guess this is, in my own experience, those who go through the state at least, they do very well. Personally, in my few patients that I've seen, though, they have no activities when going through a great challenge in years. But the major this is to give alternative life threatening ventilation that or expect to live with use. There is a little bit less. Yeah, it's a very good question. Something that we have considered deeply. There's really in neurology and environmental but not very piece of I think we're living in the same time years. We now know these patients. Most of yeah, the advances which are that with the also they don't respond very well. So the ones that I've seen, they're still declining it year on year. Maybe not as fast as they one as the other ones. The key taking message, the big and the big that's as similar as the machine. It was a kind of thinking from the new approaches that always is some I think program done for us and basically they're different and absolutely realize this place this and other issues that are unique to them. So learning that is since with experience and following study about university right sure was very working was over in Europe, the United States, Canada. Yeah, I'm pretty close to the since the Mexican the Russian but we don't really have any active data to suggest whether there is so that doesn't think now we know it was two slings. There was one today you are later around 5 years and yeah, many of us it's like This. Now that in the first month with my own mother sometimes perform twice. This is twice. Uh, I don't really know about Sash. Something that so they make like well six I know tier in the big and really have to do twice patients. But I'm influencing that some but great and then the ones that we asked about one the weekly prognosis is where there's so many deteriorating then I think without you then very the internet brings back that people like those who can do it are when they are saying they don't want to posting it how do you use it when I'm looking at the games fee there isn't very much happens about it. I think the really I know the one in February that they put in the arrested and then some dates for I to do that and the like well they guarantee it in no way. Well, wait, that I think we have the feeling that we have based all this criteria to be responsible. And that basic all this criteria to be treated with empathy, but for instance, the effect of really, for instance, the effect of will actually a truthful and moderated activity, looking for it, like, 5 to 7 years, the mobility of time is stopper. So, if you instantly find going for anything, going to spend plenty, whatever, then you're going to be a very portion. Many of them are not willing to by the ideals and profession. Really then find is to go just find them like no use the same like don't mention that. Yes, really, because in London we have a Pat London NHS, so we always speak one of the things the concept and the whole the new ways, the ways the ways really I think there is the different way you have already always based on the values is more and one of the ways I can get the rate is basically getting less. One of these even though I'm not right on the screen. This is maybe someone that the president era smaller and the message on the we haven't seen benefit. And it's a really difficult to convincingly my levels behind the cities, they back to the basic it's pretty difficult. But I would like to say the rights of the US and other things who are clearly getting worse. Looking about all the millions and things worse. But MRIs are very stable. Yeah, he's really well back. And I think, yeah, there's also a privilege of this versus this. So really has pages of getting infected in all the time. Really, infected, but they really when you do ranges of the young, in clear reason, the we used to do. There was a question now having them with the other I think one is fighting the something when the knowledge I think the reason they are good then the next time this thing being done the still needs to be which is we'll wait and see that it's a right to do that would be some feature for great to we have master that next year. Thank you for this game better than the so I believe that we will go here and thank you for the speakers and in your we will for the advice. We'll start with just one gentleman we introduced earlier. Uh, the talk will be about rethinking and disability disruption in multiple sclerosis.
Thank you very much. So yes, this is the ceremonies satellite reporting. I know it has a stigma, so I will show it the size. So we're going to be talking about disability and accumulation and how the way symptoms maybe sometimes it's limited. So this disclosure. Earlier, the patients, we think of those problems being a major thing in knowledge, mobility, gains, and cognition. However, we know now that even when we started this treatment, no relapses, data is achieved. We think basically that has doing very well, things are good, serious with it. However, reality is even with no relapse, not significant vision, patients still lapse, patients still some of them going to treatment well. And this can be multiple reasons, different symptoms, different symptoms. And this is really the trend in this process, and this is why the word is fair not to do mistakes because we tend to care about most of things that patients that's so for example, patient will tell you what my vision is learning, I'm looking from far, and then you look at the examination, there's nothing much, visual acuity is fine, but I'm trying to find explanation, there's nothing really with no explanation. They tell you that something falling, the problem is fine, or maybe in the same state as 4, but it's still in progressing. The other issues are bothersome, and also patients, even with this thing they do, they still think they're still not that possible. And this is the thing that's been always asked to pandemic back then. It's not that symptom territorial, actually do cause symptom imbalance. They cause physical sign of negation of symptoms, also affect their social life, relationship, going outside, living like a normal life, and things like this. Even if it's serious, but they really do impact their productivity, jobs, is also impact. And even emotion, they can lead to significant emotional toll, especially there's lack of understanding from the people around them because they see them walking, talking, but they still suffer. So if people around them sometimes don't understand this make the patient and a lot of stress. So these are things that we tend to be headache about it. And we know that the nurses are we thought is the main driver of disability and MS. There was no effective treatment, partly effective treatment, the last of it, still an issue. However, nowadays we realize that even with this treatment, patients who need this disability, either to be by the seriousness, the constitutional disability, not trying to be dealt by other markers or other biological reasons. And it's can be caused by just normal aging, because as we age, we tend to lose some reserve. However, there is also no biological factors that can contribute to this. More important is to eat. And then we can see this multifaceted nature of MS make these subtle signs difficult to detect. We know nowadays that even for neurosis patients, this patient have PLR reduction in common, MS is not as rare. As you can see, it can be up to 60% in some whole, and this should be related between non-trading is the real time, the population to have trading, which is paid up, you tend to have worse residual disability up to 36 months. So PRI became a hot topic in MS, and the treatment that we do, we do prescribe even the prospective one, they don't really tackle the PRI very well. And these symptoms can be negligence and employment, we're going to ask about it, and can be very visible, specificity of our speech. Now, within the clinics, we don't really focus on these symptoms. We try our best, but sometimes the patient time, single reason, we tend to focus, say, by seeing patient every year or maybe every 6 months. Include the line, the distress, the labs, and the medication pills. But we really like have the time to go through all these symptoms one by one. So this is an issue. We need to find a way to look at these symptoms and hopefully address them and treat them and improve the patient quality of life. Lots of centers nowadays they try to do different aspects of disability measurements such as this. Working with camping by football or lifting with the CMC or FASAD, or the visual acuity by little contract, no contract, little acuity, no contract, visual acuity. These are kind of subtle markers that different tablets with limits. However, this is not the whole picture. Even if you do this, you still miss it. We need more biological markers such as the PRS, hopefully they can affect pathology and progression, fluid biomarkers, digital tools such as wearables might be also a window when looking at disability. So we have the patient voice, we have the clinical goals, and the biomarker that happen. In case we know that clinical is not really full progression, maybe GTAP does better than that, but over until we these are sometimes not available easily until use. We want to look at brain atrophy, the interbrain atrophy is associated with vision loss and more disability. And also we look at nowadays more biological cages such as paramagnetic cages, which President Galan described earlier on. These are areas that we can see and like lesions, we see by the ability to make an image that indicate microglia or direct smoothing of the lesion. This is at least the theory behind this, and these have been associated with more progression, but also the slowly expanding lesion cells has also determined progression, but these are still also difficult to measure in our routine clinical MRIs. So what drives progression? We know that MS there is acute inflammation, there is peripheral inflammation. This is usually indicated by our children, but then the challenge is with the chronic inflammation, or the smothering inflammation, the compartmental inflammation, then the CNS, which is hard to target. And this is usually driven by innate immune cells, such as the tissue-resident microglia or macrophages. And this has been maybe the atopic area of research and also treatment targets the last maybe 5 years, but how can we talk these two converting the right information? So microglia and the CNS are not always bad. We know microglia is important to maintain synapses, to maintain the integrity of the astrocyte. They also contribute when they inflation to some foreign type of inflammation. So they have like good and bad side for this microglia. And they're open clearance, but with the dose degree, that can maintain the synapse variable. So microglia has been the kind of area of research. So this is usually because they also interact with that, and they also interact with being peripheral nerve cells that go into cells, cells. And these are interacting with these immune cells. Hopefully, we probably can use this smothering MS. So there have been a few targets to this mechanisms. Very good one by me. So the most interesting target was the MK enzyme, some kinase enzyme, which is present in the lymphocytes and also in the microglia. So the thing is that when you reduce microglia activation, you have less smothering inflammation, less fluid progression. In addition to the impact on the lymphocytes, which is also impacted by the proteins, calcium inhibitors. So it's kind of like a hologram which two mechanism we can do like two at the same time. And not probable have been, as you know, kind of mixed. We have a negative result for ibrutinib with our lapsing limited MS. Then we have the tuniprotinib, which became exciting when it was shown to be effective at reducing severity of inflammation of non-relapsing SPMS. However, you might have heard that the study of PBMS showed negative results for tuniprotinib. At the same time, we had good news from fenebrutinib, which showed positive results in RRS and also in primary RS, which was compared to influenza. So how to interpret these conflicting results is something we need to discuss when we see the final publications. Is some trial design, mechanism of action, is it dosing? So this is nothing we need to discuss. So this is at least give us some hope. This is the Heracles trial, which looked at tuniprotinib in the relapsing SPMS. They took patients who have diagnosed SPMS, never had an relapse last year, and they compared to the placebo. And you can see at you can take 6 months, there's a 31% reduction in the risk of cerebral. So then also you can see that the same difference in 3 months, however, it's less pronounced. And also there is an impact in terms of impact football and the disability improvements in what was that for us. Output, the lung function did not actually show the difference between the two groups. It is a significant difference. So there might be something there for this medication. The main question with tuniprotinib is the safety, specifically the liver hepatotoxicity. We have 4 patients who had severe increased liver function tests. And there's one patient who died from complicated liver surgery, transplant from So this is why this can be going to delay in the approvals. And we heard that recently that has not been approved by the FDA for non-relapsing experience. So then maybe we need to find different targets. So the newer target is CD40 ligand, which is protein that is important in the communication between T cells and B cells. So if you block it, you can cause misactivation bases and pieces and also misactivation of innate immune. So again, we're trying to improve pathway for this medication. The phase 2 trials have shown good results. The phase 3 in non-relapsing SPMS is just completed recruitment. So we are waiting to see if this is really a mechanism does more for SPMS. Then there is another interesting molecule called masitinib. This is a very unique target for us and erythrocytosis board to target mast cells to support the innate immune system. It also does have effect on the macrophage of microglia, and this also might lead to secondary abuse activation of the adaptive cells. So this is the masitinib, which has been tested in a trial for primary progressive multiple sclerosis, which actually there was no difference in the you reached the high dose, but when you shoot at it, it was a so it's actually very interesting results. With a smaller dose 4.5, there is actually the infection disability. You can see in the graph, but if you increase the dose, the disability difference does not occur. So this has not yet been approved. So I don't know what's happening to the regulatory medication. Maybe the dose response being limited down. Then lastly, this molecule for video says I think it has kind of modified environment. So it works on dehydrogenase, which is an important enzyme in the pyrimidine synthesis in the lymphocytes. So it does lead to reduced lymphocyte activation. And also it does work on the innate immune system. So it might want to work for the precursor type so by binding to nerve receptor, so all of the want to improve part of the immune system, don't want waiting to have a case taken the trial, and hopefully this might also cause some. So there is work to be done in progressive test is the good security activation. Normally, the new medication are targeting the innate immune system. So hopefully the medication can lead to improvements. So summary, We need to look for a progressive MS, maybe with newer tools, small sensitive tools that address the symptoms that the patient describes. And we need to understand better what drives this inflammation, what makes this failure happen. Is it neurodegeneration? What that to know the drive inflammation, or it is other side. And by that, thank you very much. But they have putting introduced content. This is one of markets. I'm honored to introduce Professor Mutalban, Shafii Mutalban, who's going to be talking about new data, autonomic centers, and global insights in this presentation. Professor Mutalban, we've introduced him earlier, but doesn't introduce him again. He's Barcelona. He's the head of the MCAS, is one of the largest centers of multiple sclerosis. Is also a co-chair of the Traffic Foundation. Welcome, sir.
So thank you very much again for the introduction. And let me just try to get my slides. Thank you. This is my preferred slide. My institution will receive a fee for my task today. So thank you very much, Tawadis, for inviting me to give this talk. Let me just show you one case, which is a real case. A 60-year-old female with no relevant aspect of history. In the 2014, we had some acute neurology we observed the beneficial activity of the left eye on the following days. So the notice that the acute neuritis that was the awareness. So we perform breakers for the brain. Here you see the not the value of the examination. Anyway, and you see the solution there. You let me just go with it. So the question here would be, does this in fulfill the 2017 patients put to the abdominal criteria? And the answer is yes. Now, only dissemination in time. I need the question that I have asked you in the red big. But probably the right one, let's see if it is I need more information for 2017 criteria. And then here, let me just go here. So you can see this is the window the body will start working in the subrenal region with the tumor, the real spinal cord. So there are different involved. In 2015, we were not able to make the diagnosis of multiple sclerosis. Nowadays, with the 2024, we have a 5 authorities, even if authorities involved, you can make the diagnosis of multiple sclerosis. Right. On the other hand, we we're going to plan in the CSM and also calculations were not observed. Yeah. So in the maximum of the investors, not three patients, gentlemen, something right is my one, she reported Lily, just wait, see what happens with improvise, etc. You can decide to treat the patient with the first line therapy, which the therapy right or tools that you for each listener, and also the provide with the foreign. You can decide to treat the patient with the conditions therapy in our house. It's what the is. All of them scientists therapy are by and it's what people layers. And other information is to make this. So I think build was built really mentions that the important is in Finland will I think the answer for all of us is very yes. However, in legal practice, when you go around, you have the data, you realize that quite a large percentage of patients, naive patients, start not being highly administered applications. Even in our pets, brother, this is all human interaction. Now we have to find against human interaction. The why we have to do it's clear that we have inflammatory activity, at the very early stage, we still use from with the inflammation and what we now inflammation. Yes, sorry. Let me just show you one, two, three examples about the this is the one of 19 very accomplished and very humble and you're really watching. But this is a paper coming from the Danish with the regularly wrong with is the one of the only almost mandatory registries available. So the quality of the data of the registry is very high. And when we did was to speed the patients in those who had an treatment and they consider conventional like the visit in the first 2 years has been the first symptom with a large number of patients, about 2,000. And so they compare that group with those who started between the second and the year after they got us. And differences were pretty clear. Patients with later treatment start show a 42% increase as rate of maturity diseases for 6 months out. So mortality was increased by 38% in the later studies. So we will tell our closing and the difference was very clear. There are many examples for I already know this and probably using different um, different approaches, the long-term randomly different. So during this case, evidence show you this vehicle where we tested the wrong chain a couple of years ago. We explained our CI for 20 CIS pages in three different and we compare those who were treated within the first 6 months and those who were treated for 1 year and a half. So it's not a huge difference. First 6 months and for 1 year and a half. The feeling just things are not beautiful and the things were different. One to receiving experience things, reaching the so all of them were beneficial for those who starting within the first month. And the next question is, what about if we start within the first 3 months? What about if we start within the first 2 months? We're trying to get the adult level pieces to answer this question. Again, if you use drugs in other areas, clearly a stage between the cities, even feel boring, to mind, is much higher than when you use the same medications, relax and maybe source of relation. So the earlier you start, the better the outcome. Following question, high efficacy, only high efficacy is not beneficial for patients, and there is you can implement real data and how much themselves, and I'm going to show it all. Them this is built by a team as far as I know, this is the Spanish paper on this, doing the registry using a propensity score, they at the end dynamic patients with escalating approach against patient with early intensive treatments and the outcome were different in both groups. They were in patient with life them. But the media is 99 shows which shows as well. Which by Burrell in Palestine relationship, they can make the same thing concept. And you can describe the papers themselves, but the same concept. Early treatment with high efficacy is the other way around. Another one And once in the Romachi, same figure as you can see. Consider will stop in high, very high figures. Probably they will patients that they will grow out in a higher proportion. But this was not the case for this fever. And I think this is the we found a similar probability of this in the way for the elements. It's quite reassuring. What I'm not going to describe that. I'm going to link down. It's very clear and it's been very famous paper. And say that when I went to this 3 years ago, last 1 year, when I showed the system involvement, but they told me that they didn't completely shift in the way of treating patients, and it was this, and now they're using in fact, I think it's very emotional therapies, specifically in toxicology. I have to be honest. They're just finished just a randomized trial comparing everything surrounding socializumab like that. Tell me other results. Okay, what else do we have here? The second number I should be yeah, the degree, same. So once again, data coming from real world data indicates the same. Very high efficacy therapy is better in the long term. The only term make with that concept it's coming from what just one note saying, hey, this is correct. But if you start high efficacy therapy in very advanced patients, such as SPMS patients, it is you're really going to find an activity about so we will just talk really on the other sort of try to integrate the same concept from investigations of that randomized trials. And let me just show you this is coming from the current trial for Vietnam. So once start working, once you switch all patients to open the is actually the current now run parallel the but this line is it will never be recovered. And the reproducing the trial not the same thing. So once the patient switch to Zumab, they run parallel, but with this they never catch up. We will talk about the same concept. The difference between the Tumam and the ones filled with the Humide. Once everybody is treated with the Tumam, the burn is flat now, but they never change. One slide just to indicate that although the C20 are not the final solution, they do have a program interesting combinations of very activity that we don't identify because we don't use MRI function, but they may have something like that. And regarding naive patients, should we use Fatuma in a high risk therapy in naive patients? Of course, we do it. We still know that for example, data that show the emplicity that the agents. Let me just remind you that apart from the food indication, it's not like treatments. Using efficacy very early on, we have to monitor the treatment response. Otherwise, we're making a mistake. But nowadays, the final outcome, the main outcome is need. We don't want acute focal rate activity nor distant approach. It's one slide indicating that this was actually coming from our lab in blood picture to skill publication. Then when we have patients to relative severity, and after 1 year they were in, but they have high levels of neurofilaments, the needle will be lost in 1 or 2 years. So just for us to take that into account. So I finished my talk. This is just to indicate good living analysis using sometimes investigated tools. the equipment and I think it's very very good. But also remember that the treatment of MS patients is quite complex. It's multidisciplinary approach. This is what we do. And then sometimes the neurologists are there for the least important professionals in the care of MS patients, social workers, nurses, neuropsychologists, speech therapists, sound therapists, and physiotherapists, lead all of the events activities in our center, and also work within scientists, basic science, and other people as well. And this is our group in the lab, the group and the MRI development as well. So I thank you very much for your attention.
Very much to so anyone have a question for anyone who learned? Okay, thank you. Next is especially my the last sequence of this response by there. It's my pleasure to introduce Victoria Metals team for the this and the German knowledge that came back this playing the map. She did a training Harvard hospital and also did the master of PhD on Newson's synthesis.
Thank you so much for the introduction. Have the slides, please. Okay, so we are going to talk today about the impact of early use of high efficacy therapies in relapsing and relapsing multiple sclerosis. And these are my disclaimer. That axonal damage occurs early in the MS disease process, and usually this axonal damage happens in the areas with the highest inflammation, active inflammation, and usually happens early in the disease. And as we go on with years, this axonal damage occurs less and less. Although the patient most likely is recovering from the attacks, we can see from mentioned MRI studies that in the finally we are seeing healthy controls. When we are doing a simple motor task, we need a very small area of activation. The same motor tasks, if we see an MS patients, requires a very high area of activation. So this is just it indicates that compensation is still compensation. It's not still recovery. And by time, this will break down and will lead to progression. And that's why we need to regulate activity early in the disease to minimize the cumulative resonance. And we have been hearing from the beginning of the day the importance of early treatment. Here, communication is only by starting late nervous years comparing to early 0 to 3 years, we can see big difference in the cumulative hazard of progression. Also, in the conversion, relapse remitting multiple sclerosis, secondary progressive multiple sclerosis, we can see a difference if you initiate platform therapies versus high efficacy therapies. This is a very important point that compares the mechanism of thousands of different treatments in multiple sclerosis. You can see in the upper one, we are talking about modulating therapies, the interferons, the interferon, terfenamide, and dimethyl. Once you start these medications, you are going to have a specific period, and these medications are going to start working, and the immune suppression will come. And during the active time of that medication, you are going to have a treatment effect. We're going to see with creating therapies when are going on, and that is sequestration means that they are trapping the activating T cells in the lymph nodes. mechanism is preventing the T-cells from entering the central nervous system by a blockage of the blood-brain barrier. We are having activated cells, but not accessing the central nervous system. So you are going to have some element of immune suppression. The problem with these medications, as you know, that once you stop them, you are having a risk of a rebound. You know, in therapy, we are the cell therapies, you are going to initiate them, you are going to have increase the B cells, and you are going to have an increase in the immune system that is going to uh, uh, make you prone to infections. And when you stop them, that effect is gone. One quick to immune reconstitution therapy, and we have heard in the morning about the most strongest one, the immunity stem cell transplantation. And there are other ways of immune reconstitution, which is clethodim tablets and alemtuzumab. Here you are going to use a very strong suppression, and then there is covering, and then there is another dose in a subsequent year for alemtuzumab and clethodim. So I don't see doing it one time each. Why this is important? Because the efficacy of this treatment is something beyond the degree. We are treating the treatment, but still you are having an effect. And we are going to talk about why this is important. Social therapies are here by environment therapies for sclerosis. This is an experience in France where there was 100% consensus that they delay progression of the disease, and they are at 93% consensus that if used early, they must be used as early as possible to have the advantage of reducing inflammation, and 78% consensus that immune reconstitution is more qualitative when it is performed early in the disease. So how is clethodim working? Clethodim enters the lymphocytes and is activated by specific kinases, and it can induce lymphocyte apoptosis. What is the difference with apoptosis and necrosis? Once apoptosis happens, the cell will lead to apoptotic plants, and they are going to be engulfed by scavenger cells. This is then going to lead like the necrosis. Down, you can see down under here that when a cell is necrotized, it's going to release some cell lysis, cause inflammation. So it's not going to lead to inflammation. And this is in general how immune reconstitution happens. When you are having a disease, you are going to have an active immune system, you are going to have a lot of B and T lymphocytes. Their tones are the ones that are activated by parasympathetic system. The blue ones, they are there, but they are not impacted. Once you do any of the three modalities that we say, whether it is cells, we are over never being able to sit up, you are going to have a severe down of these cells. And once you stop them, you are going to have an institution of these cells. But hence, the percentage of these cells which are different, the similar nervous system, are the ones that are more advanced. It is like we send them when we are having like then we see them holding again, then it's reformatted. This is kind of what I explain to my patients we are doing in these mechanisms of this. And once you are giving it, you know that it is effective, and you have 77% increase. 77% patients are relapse free. It is common that I see in my clinic that the patient is saying, one is what we haven't done within 2 years. We are assuring them by the extension studies of clearing and stopping the medication, you are still having 75% patients relapse free. So this is truly an immune reconstitution. When this is on as a more cellular level, we are seeing like targeting 2019 cells in the first dose and then the second dose of the second year. And this is something independent of what we see with alemtuzumab. So you have the tips during the giving the medication, but in alemtuzumab are seeing a hyperregulation, which is believed that maybe contributing to the immune phenomena that we see with alemtuzumab, like the atrial thyroiditis or the ITP. Components T cells, and you can see more lines with the CD4, the CD8, and the modems that are seen also during the dosing of this disease. Sorry, that's not this medication. So, what is the importance of this mechanism? You know that these lymphocytes are important. These lymphocytes that are the main barrier to infection when we are getting them. So they act as field surveillance. That's why they protect us from developing malignancies. So yes, we need to target them, but we don't want to leave them on the level maybe targeting is actually is after you are finishing the therapy, you don't have to have a very long term monitoring like other medications. Other medications we have used to every 3 to 6 months. Liver functions, CBC, you can achieve this medication. It's following out from the adequate time. You don't need to follow the to follow to do the monitoring anymore. So that's why it's important to know the mechanism of action because the lymphoid is not that severe, it's transient, selective, it develops bonds, no acute information, and also it is not associated with the renal phenomena. So and this is also comparing Letterman to Fingerling at this is what you see, for example, in your clinic. You have somebody on Fingerling and he has a lot of his CBC was coming with a very low lymphocytes. It's just to the sense of Letterman. These are one of the this is for one of the patients that I switched to this medication because I would not go on the severe lymphopenia induced by other medications. And they did well after switching to Letterman. Same with omalizumab, which will have also a very severe anatomumab lymphocytes. And it's really affecting side effect profile, yes. Since it was approved in 2017, it's estimated that more than 100,000 patients have received therapy. We see a lot of profiles and adverse effect profile of this medication. Hypersensitivity, a very low serious side effects, some liver injuries with zoster malignancies. Also, it is not that different from the control. Also, they didn't see any specific clustering of specific malignancies to systemic. And very important as well, there is no PML gigs. So if you have a patient with spontaneous that converted the JC5 status, this can be also a medication that you will consider. And also when you are having some patients with therapies with, as we said, repeated or repeated infections, also this is a good thing to consider. Here is comparing cladribine and omalizumab side effects. So I have been saying that it's a good thing to work from other medication if you don't have if you don't have choice, this is a good medication, but also it learns. So in this from the rectify and the clarify studies, this very effective when you are starting with very naive patients in reducing the annualized relapse rate. And so, time to first relapse, you can see when it started early, starting to early before any other DMT was starting it when other DMTs has failed. It the probability of first relapse is better when it started in naive patients. And in EDS, as you can see, it is better when it started early versus start late. Um, also the patients are a risk of uh, thyroid is less when you are starting this medication early. Sometimes you are actually told to switch these patients, but you can see that switching other medication, they have they did recommended better in decreasing the last relapse. Okay, so we the effectiveness of letrabine in first switch patients we can see here. Switching from any medication, either naive or injectable prior to a platform or by efficacy medication, and it increased the annualized relapse rate. And also, proportion of patients with this needed three was less when the patients when were started, many patients who started with letrabine versus three with paracetamol. The thing probably when you compare the ESS with ocrelizumab, it showed that when you switched from either ocrelizumab or the patient, or from comparing patient who were for the cladribine, they didn't anything worse. This was a Sydney cohort. It happened during the COVID 19, so there was difficulty in collection of that. But still, we have to mention this stuff. Um, the Filipina study compared switching from mechanismab to mechanism. Because when you are one mechanismab, you are afraid that you are going to have the rebound relapse. But here you are to press the annualized relapse decrease if you start comparing 4 weeks after stopping the mechanism. Switching and then so we talked about switching, we talked about here. Let's talk about really learning strategies. If you have a patient who is older age, we have heard in the morning about the immunosenescence, where rapid decline in the immune system activity happens on the page. This is going to lead to infection and decrease in vaccination response. So this medication is also uh, a good choice for patients who are over 50 years of age. And you can see that there was a very good sustained minimized relapse rate years after stopping the medication. So the effect on ADS. Here it shows you how the effect on the sides that suffers than people who are less than 50. There is no safety signals in real. So yes, it is surprisingly more during the dosing. There was no safety concerns. This is also going the data. And also another thing that you know that when you are using the basal therapy sprays, you are going to have a risk of increase in the IgG. This has not been seen in therapy. Also, I had a patient situation of basal therapies with a very, very severe decrease in IgG and repeated infections that did well. Here we can see how it is placed in different algorithms. So in summary, it is important to start treatment early and ketamine demonstrating high efficacy benefits, and it has a good safety profile, and it can be used as a de-risking strategy. I'm going to go quickly about our 18-year-old female that she had right communication months. She came from clinics for investigation of epilepsy. And this is what her MRI showed. And of course, when you see something like this, and they refer with some white matter still, she had other things to recover. But then you do more belief checking the hospitals, but still you don't believe that. Then we can see some list of articles. Then you get the spinal cord. And this spinal cord was really shocked. And we still investigated further with the negative like that, which was positive. We did but we did that really less like spinal. So we are huge one negative. So we have to label them as and she was, and then we had another MRI afterwards, and she showed a positive new lesions, so she confirmed the diagnosis. We started her, we started her from I don't know what to say. When you visit went, even she was in here, she was from she said you know something priority start over medications, going through the medications and when the waste reach the separating smaller. And she said, "Okay, that is because sounds I'm ready to do that." Even when in the long run, feels good. It's not that in this start. Humans say that when she's young, she get married and get kids, but she was still baby. I had another one who was 27, and she is more likely to get married and have kids, and she presented with a tumor factor. So she was very, very thoroughly investigated before being able to as well as she was started living in Mars. If you came for that city dogs because she learned that. So I want to but you can see that I started the first one in August 2023 and it's starting the second dose in October 2024 and only Johnson been done since fall of 2025. She got married, she finished 2 years, so pregnancy and everything is going fine. And with this, I conclude and thank you so much.
No question. I think we will take this will put the best morning. We have lunch now and the lunch will be 10 o'clock. We'll see you at 1:30 p.m. Thank you. So we go for your prayer, then we'll join the room at the lunch.
we want to start session 3, which I told the hidden elephant in the room. So in a moment, one class, you will find a lot of my neurologist, but no one will talk about the patient of the life. So in this session, the moderator would like to know about Abdul is a neurologist in the neurology, the neurology planning in the global Medina. He is now known with promoting the API with the training for residency programming syndrome and team assistance. The second moderator will be Dr. Ammar Hassan. Dr. Ammar is a consultant specialized in maternity and mental medicine. He has children with design. He's the deputy secretary from medical service and president of the university. He the national down build that.
We'll start with maybe first presentation, is it the urology presentation with title of sexual dysfunction in MS male perspective. It will be presented by Dr. Hattam Badr, he's a consultant urologist and urologist, and starting with the executive director of research and innovation at Imra Abdullah Medical City. Welcome, Dr.
Thank you so much for this kind introduction. Thank you so much for the organizing committee for the invitation. Today I will speak about sexual dysfunction in multiple sclerosis patients from male perspective. The presentation, please.
And we have the slides.